Today, this evening, we are delighted to see friends new and old, to have opportunities to continue to learn, and to celebrate decades of work from Drs. Reitav and Thirlwell. Uh, Dr. Reitav and I got to know each other almost, is it 20 years ago? I had recently joined as a medical director here, and we believed all the way along, and this program has believed for many decades, that the connections between the mind and the body are indeed important, strong, need to be explored, celebrated, investigated, managed as best as we can. And it requires insights of really thoughtful people with great innovative abilities. So we're delighted when Dr. Reitav decided to join us. He's had a long career as an educator, working at different institutions, including the Canadian Chiropractic Memorial College. I'm trying to remember things off the top of my head. Jaan has worked with, now in a span of 20 years, if I roughly roll this up, you've worked with over 35,000 people in this period of time, had important impacts on so many of us in the room and online, plus waves of individuals outside as well. So Dr. Reitav and his colleague, Dr. Celeste Thirlwell, I believe, thought that they should put some of their amazing findings and thoughts onto paper, and they've brought a book to print. And this is one of the reasons that we are celebrating, in addition to a very distinguished career for them both. So at this point, let me turn this over with a lot of gratitude and a lot of anticipation for an exciting next 60 minutes, 90 minutes. I don't know how long this is going to go, but it's going to be great nonetheless. Dr. Reitav, I'll turn it over to you.
Okay. Wonderful. All right. Thank you so much, Paul. I can't believe it's been 20 years. It's flown by, literally, and I'm so thrilled to be here. And I want to, right off the top, really express my appreciation for Paul and everything he does here in leading our team. He leads by example. He is dedicated, he's curious, he is open-minded, and it's been just a pleasure working with you, Paul, and as well UHN and how they have supported us in what we're doing here every day for our patients. And tonight, this is a book launch of what Celeste and I have been working on for about 5 years. So it's amazing to me how long it takes to get a book in print, but or maybe we're just slow writers.
COVID.
COVID, yeah. COVID is our excuse. So, but what we want to do is to also celebrate the importance of our patients, because truly it's from my patients, the people that I work with every day, that I've learned so much and that have led me to what is in this book. And I believe, and I hope I'm right, that there is a new perspective here about how all of us in cardiac rehab should be doing psychological treatment. So stay tuned as we kind of unfold that story. To give you kind of a sneak preview, the main theme in the book, or the main character, is a little blue dot in the brainstem called the locus coeruleus, which is Latin for blue dot. And why it seems to be so important is that it coordinates so many of our psychological and cardiovascular functions. So this slide is just to kind of get you thinking about this theme of something that's happening in the brainstem that is affecting us, not just in terms of our heart rate and how fast and intensely our hearts are beating, but as well how we respond emotionally to especially medical conditions like heart attacks. So we'll be coming back to this fairly frequently, and especially by the end of our talk. So We have objectives, 4 different things that we would like to review with you. The first is to kind of update you on what do we understand about how psychological treatment should play a role in the recovery of our cardiac patients. So I'll briefly cover some of the most important guidelines for that. Then we're going to talk about how looking at the individual who has had a heart attack, look at their individual experience, their internal sensations, and what is happening to them as they're going through those experiences, those life or death experiences, and how that really changes in some ways what we need to be treating. After we talk about that, we're going to present 3 different case situations, which include Takotsubo syndrome, insomnia, and depression, and then basically look at what are the implications of all of that for how we treat people who've had cardiac problems. So let me begin with the review of what do we know about cardiac rehab and the psychological treatment. So I arrived here in 2005, and the year before, there was a very influential and classic study called InterHeart. It's a Canadian study we can all be proud of, out of McMaster University. And what they did is they looked at over 1,000 people around the world who had had their first heart attacks. And these people were enrolled in study in which they gave blood, their blood pressure was taken, their activity levels, whether they had other medical risks like high blood pressure, diabetes, but they also included measures of stress. And so what they looked for was what was the prevalence adjusted risk from different risk factors. And they found that cholesterol was the most important risk factor around the world. No big surprise there. Smoking was a close second. Again, we've known for decades that smoking is not good for your health. And surprise, surprise, the third most impactful risk factor was chronic stress. So, and that accounted for more of the risk than diabetes and hypertension combined. So here are the figures for North America. This is broken down by area of the globe. As I said, the study was done in 52 different countries, 1,000 patients. And in North America, the prevalence adjusted risk of lipids, which is the second last column on the right. Actually,
Excuse me, Jan, we can't see the slides, us that are online. Oh, now we can. Thank you.
Now you can? Okay,
Yes.
let me see. And if I go, can you still see it?
So, Retief, can you put it on slideshow?
It is on slideshow now.
It's not coming up a slideshow.
Okay, give us just 1 second. We can sort this out. Stop sharing for a moment. It just stopped sharing for a moment, but it's going back now. Okay, confirm online that you can see it.
Yes.
Thank you very much.
It's still not in slideshow mode.
It should be. It is here.
How about now?
No.
No.
It has
You're gonna
always
have to-
been. It's
we
always
can't-
there.
Yeah, you're going to have to advance the slides one at a time for us to see them.
Okay, can you see a slide at this point?
Yes.
Yeah.
Slide is
Yes.
it.
Yes, yes, lovely.
What color is it?
Oh, is this a test? It's blue.
It's blue.
Okay.
Blue.
Okay.
Did you see the white one now or no?
Nope.
Did it
not
change?
right.
Not yet.
No. No.
Still blue?
Yeah.
Nope.
Okay, it seems like some folks are having a little lag in your system. If you just hang in there, be patient. For the sake of the flow of the presentation, I'm going to take the prerogative and put you on mute. That sounds very mean, doesn't it? But it'll allow our presenters to do what they need to do. Yeah. Okay. And okay, let's carry on. Okay.
All right. Thank you. Okay. So basically, on this slide, you have the prevalence adjusted risks by area of the world. And in North America, lipids account for about 50.5% of the, just put it on to pointer, about 50.5% of the prevalence adjusted risk. That's from cholesterol. And psychosocial stress factors are about equal to that. In North America, actually, abdominal obesity is a bigger risk factor than both of those two. So it would look like stress is equally important to lipids. And over here we have the impact of hypertension and diabetes, and together they add up to about 25% or about half of the impact of psychosocial stress. However, if you look at how psychosocial stress was defined, it was a composite. It was not just a single factor like what is your cholesterol level. It was based on the answers to a number of different questions, each of which accounted for about 10% of the overall risk. So the amount of risk from having stress at home or at work persistently or constantly added about 10% risk to the overall risk of a heart attack. Having financial stress added about 11%. Having stressful life events. So these are major life events like somebody in the family either passing away or having a major illness. COVID would be considered a major life event. So having 2 of those or more in the past year. Feeling depressed, clinical depression added about 10% itself. And most interestingly, all of those previous factors adding about 10% or about an equal amount, the one that added more than the others was what's called your internal or external locus of control. So this is a psychological variable. It means if I have an internal locus of control, it means that I have the view that what I do day in and day out makes a difference, that I can have an impact on the world. If I have an external locus of control, it means that basically I feel a little bit like a billiard ball, that I kind of try and get somewhere, but somebody or something knocks me in a different direction. And so things happen to me as opposed to I can feel in control of my life. And it's interesting to me that that's technically not a stress factor, but it is a very important aspect of how I see myself. And if I don't feel any agency in my day-to-day world, it seems to put me at greater risk for having a heart attack. So what are our Canadian guidelines for cardiac rehab? So these are the main guidelines. And I just want to quickly point out that
we can still not see the slides. I'm so sorry to interrupt again.
Okay.
Well, we can see the slide. It's just that you're not.
No
reading
slides
the
whatsoever.
next slide as you're talking. It's not turning.
It's not turning. Okay. End the show. Okay.
It's good now.
Google suggests stop sharing, go to slide show, and then share.
Well, maybe we have to make that, yeah, and then now share.
I imagine you're not seeing the slides at this point. Is that correct?
Yes.
Correct.
Yes, we're seeing you.
Just a suggestion. Are you presenting this file from your computer or from a server, a SharePoint? Because if you present it from your computer, you might avoid that, the problem
It's-
with the slides.
It's being presented off of
The
a
computer.
desktop.
Yeah.
Oh, okay, never mind then.
Appreciate the suggestions, folks.
It's interesting that it doesn't have the.
So sorry, if you look at the top of the screen on your computer.
Shift F5 to start the slideshow from the current slide. Shift F5. We still see the preview, the 7, 8, 9 on the left-hand side. You need to, like for us, you know, the slideshow, it's not in the slideshow mode.
Okay. We appreciate the feedback. We're seeing something different here. And let's see, what else can I do?
Is the window, did we open it up? But it doesn't show. It only shows, we did open it up as a
Can you see anything at this point, folks?
Slide 8.
Yes.
Slide 8. Perfect.
okay. So maybe I'll just leave it in this mode because
Yeah.
they can see this mode.
But you'll have to keep switching the slide as you speak.
Yes. And we've been doing that all along. Thank you.
Okay, we're not seeing that then.
Okay.
Okay. So,
And now you can see the next slide?
Yes.
Okay.
all right. We figured it out.
No.
All right. That's why they pay us the big bucks, right? All right. So let's go back, find out where we were. So the current guidelines for psychological treatment for cardiac patients. So the first point is if someone comes in the door and they screen positively for either depression or anxiety, then we should track and make sure that they get treatment if they need it. And if they currently have issues with either depression or anxiety, they should be tracked and treated. And then further down the road here, it says that patients who identify ongoing stress, but who are not actively depressed or anxious, meaning they don't meet the criteria for DSM diagnosis, they also should be offered participation in stress management programs. So it's kind of a combination of some people who are meet the criteria for depression or anxiety, but even those who don't, if they are stressed, they should be treated. So Wolfgang Linden, a psychologist in, I think, Vancouver, wrote a meta-analysis looking at what were the effects of psychological treatment for cardiac patients. And in that, he basically highlighted a number of things. So we should assess both distress, the level of distress that individuals feel, as well as depression. But not just when people walk in the door to start their treatment. As well, we should repeatedly evaluate because some people may not show up with those issues until later in their treatment. And they also pointed out that psychological treatment should target the reduction of physiological distress, not just talking about what could be done, not just education about, things like depression, but as well actively intervening so that the physiological distress does reduce. And then there's the gender-specific psychological treatment that female patients may need additional attention for emotional processing issues like caregiver responsibilities and all of those things. So those were kind of the guiding principles as I was beginning here at Toronto Rehab. And then a number of years later, this study was released where they showed that people who do not come for any kind of cardiac rehab have the most recurring cardiac events across a 5-year period. So that's the line that's at the lowest level on the chart. In the middle, these are people who have cardiac rehab, but no stress management training. And then the upper line indicates the number of people who had recurrent events across the 5-year period. But these are people who've had both cardiac rehab as well as stress management training. So you could see an advantage to doing something that helped reduce the stress levels of these patients. So that was very important and very encouraging. And then 2 years later, in 2017, the Cochrane Library. So this is a review of all the published research in a given area. And they did a review of psychological interventions for coronary heart disease. And this is their conclusion. They said that there remains uncertainty on what are the causal mechanisms that link depression, that is a mood disorder, or long-term stress, or worse cardiac outcomes. So those two things need to be kind of elaborated, what's leading to the cardiac problems and what's leading to the psychological problems. They added that future research should clarify subgroups like depressed people compared to those that have, let's say, panic disorder, and look at whether particular treatments are effective for all groups of patients. They added that future research should develop interventions that improve both the cardiac outcomes and the mental health outcomes, because in their review, they couldn't find clear evidence that the cardiac outcomes were improved, even though psychological treatments did help with the mental health outcomes. So they felt it was still up in the air whether or not psychological treatment could actively improve both. And their conclusion, our understanding of psychological treatment effects are unlikely to become clear until there is more clarity about what is it that's causing both of those two things. So with part 2, we are now going to kind of add the perspective of the patient to what it is that we do. So my colleague Celeste Thirlwell is coming up.
Hello, everyone. Aside from the academic acknowledgements, I also wanted to thank Jaan Reitav for getting us to this point with a published book. She's a grade school teacher, and only an organized grade school teacher could have herded 2 academics to show up repeatedly for years on end. And I'd also like to recognize Alexandra Fernandez, who's taking the next step to get the book out there and promote it for us digitally. And Jaan and I would still be trying to write if it weren't for both of you. So thank you so much. So I get to speak a bit about life and death. So your brain is set up to avoid death. And the detector of that is your brainstem, which is right down here. So you have your thinking, wise mind, you have your emotional mind, and your brainstem. When danger comes, when there's a life and death event, when you're having a heart attack and you feel like your chest is being crushed, the brain goes offline, the emotions go offline. All that's working is the brainstem, setting you into fight and flight. And then your heart rate goes up, your blood pressure goes up, and you feel this intense fight and flight response, or sometimes a freeze response when the danger is too intense, like a dinosaur chasing a small turtle. It'll stop so that it can't be seen. So people will release dynorphin, which is almost like an opioid, internally in their system, so that you wind up just being in a shock state. And that happens not only to cardiac patients, but other medical patients, but also their family members. You know, it's incredibly shocking to see your loved one being carried away in an ambulance and you don't know if you're going to see them again alive. So Dr. Reitav has done some amazing work here, thanks to Dr. Paul O, who has always been very supportive in terms of bringing our understanding of how we manage cardiac medicine and medicine in general with patients who aren't just brains, but who also have emotional reactions and automatic reactions coming from the autonomic nervous system. So the autonomic nervous system has an on branch and an off branch. So in trauma, the on branch comes on, which is called the sympathetic nervous system, and there's no off to hold it back. So what Jaan is doing in his treatments with his patients that he sees post-cardiac event is he's helping them to promote the off system, the parasympathetic nervous system, so that the car no longer goes of the brain and the emotions go on 1,000 kilometers an hour. We can then push the off so you can fall asleep at night. So you're not triggered during the day with memories and flashbacks or other triggers. So who here has been through the treatment program? Thank you. Any fight and flight responses that you want to share that you looked through, that you felt? Anybody? Flight response? Heart racing, thinking you're going to have another heart attack.
Never fall asleep.
You can never fall asleep. Right. Because once your brain learns there's danger and it needs to protect you, it puts on the on system, and then that keeps that on system hypervigilant. And so it's saying, well, we can't let you sleep because something might happen and we got to keep you alive. So we're just not going to let you sleep because we got to be vigilant as to what's going on. And so that's in terms of the DSM criteria, that's the diagnostic criteria for trauma and PTSD. We talk a lot about the system being on hyperarousal, so unpredictable emotions, flashbacks, and that leads to strained relationships, increase in headaches, sometimes even nausea. So, and it doesn't only have to be emotional trauma, it can be physical trauma and injury as well too. And I think that's what we need to recognize, and I think that's what we highlight in our book, is that these systems are all interconnected. They can't be seen as silos anymore. If we truly want to help people heal efficiently and go on to have optimized quality of life post-medical incident. So some other MI patients, people have heart attacks, they talk about an elephant on my chest, feeling hopeless, isolated, alone, trapped, not being able to do anything. Remember, Jaan at the beginning of the talk was talking about that internal sense of having no control, that I'm a ping pong in the world. I'm going to die. Completely dependent on others for survival. And so what we want to do is move forward from this locked in memory or wound of trauma and rebalance the autonomic nervous system. So we rebalance it, like I said, from this high on state of the sympathetic nervous system to rebalancing with promoting the parasympathetic nervous system. And triggers for medical trauma that you can think of, we talked about the cardiovascular, they can be surgical procedures, cancer treatments, chronic pain syndromes, breathing problems. That's asthma can really be very scary for people. And then, like you said before, you just can't fall asleep at night because the brain is going, oh no, you might die at any moment because you can't breathe. And these things need to be more carefully looked at in the medical world in general. And with trauma, you can get residual body symptoms. So trauma is not only registered in the brain with fight and flight, but you get these strange body symptoms like phantom limb pain, or feeling that your body is not your own body. You start ruminating and worry for your loved ones. You have recurrent panic attacks. When you don't sleep well at night or deeply at night, you can have non-restorative sleep where you're not going into a deep sleep. So you wake up feeling unrefreshed. That heightens the inflammatory system. So you start getting aches and pains, neck, shoulders, back, feet. You wake up feeling stiff in the morning. And so all these things compound, pile on top of the initial incident. And so if we want to look at where we are, where we're in fight and flight, it's this part, the survival state, the brainstem that I was talking about. Then you have the emotional state, the limbic system that phylogenetically was evolved on top of the brainstem, which has to do with your emotional state Am I loved? Do I feel cared for? And then the executive state, which is really the cortex and the frontal lobe, which governs how you function within society, how you evaluate a situation. When you're stuck in your brainstem, you can't evaluate a situation. You're just in fight and flight. The situation might be perfectly safe, but you might perceive it as dangerous. So that's where we want to bring on. We want to, with therapy, calm down the brainstem, bring the autonomic nervous system back into balance, so then you can reconnect it with the emotional state and reconnect it with the executive state. So all these three parts of the brain work together rather than isolation, as we have in trauma where you're just stuck in the brainstem. And with regards to cardiac patients, this brainstem activation can, with the sympathetic nervous system, can activate the heart, or with the parasympathetic nervous system can calm down the heart. So decrease heart rate, decrease blood pressure. But if you're in this continuous state of activation, your blood pressure is high, you have a high heart rate, your brain, like I said, is going 1,000 kilometers an hour, so you're not turning it off. And that's why it's so important that we regulate this. And a big part of healing is helping patients learn to sleep again and really doing a thorough workup on all their sleep issues, which Dr. Reitav has been excellent in doing over the years. So if you want to get into the nitty gritty of it, he had mentioned the first part of the talk, the star of this talk is the locus coeruleus. And when you're feeling safe, the locus coeruleus releases oxytocin. Now, oxytocin is the hormone, is actually the love hormone. So when you're in safe relationship, when you're in safe situations, it's also released when a mother breastfeeds their baby. Oxytocin is released in the baby's brain, oxytocin is released in the mother's brain. And that oxytocin from the paraventricular nucleus then goes down and impinges upon the locus coeruleus right here in the brainstem, our star of the show. It inhibits it. So then, because the locus coeruleus is inhibited, the rostral-dorsal-motor vagal nucleus then goes on to decrease heart rate. And these other two nuclei also go on to decrease heart rate because you have increased parasympathetic nervous system tone, increased off. So that's when you're calm and you're safe. Now, when you're not calm and safe, we have all these things going on in which corticotropin releasing factor and vasopressin, so all these cause an activation of the sympathetic on system, activating the locus coeruleus, and it's orchestrated through all these nuclei within the brain. There's several of them. And from there, we go on to the locus coeruleus now being turned on is going to, on a cognitive level, thinking level, reach all the way up with norepinephrine, so an excitatory neurotransmitter, to activate your cognitive system. So there's danger. You start overthinking. You start seeing the negative in everything. Then you go down to over to the periaqueductal gray over here from the locus coeruleus up, gets activated. So that begins these stress responses. So ruminating, emotionally feeling overwhelmed, like there's a catastrophe. Oh my goodness, I'm going to die. I can't get out of this. So all those catastrophic ruminations. And then to add insult to injury, it's also affecting the cardiac axis, as we talked, by activating these other nuclei, inhibiting the activating nuclei so that the activation continues, so that you get increased heart rate and increased blood pressure. So that's the background from a life and death, fight and flight, let me protect you brain. And we're going to hear from the people who taught us most of what we know, which is the patients. Thank you.
Okay, so thank you, Celeste.
I just wanted to check out these little messages. Make sure there's not going to be any little digital saboteur for this presentation. You have 8 hours to finish this talk.
Okay.
How was that?
I don't know. What do you think, folks? 8 hours, we'll watch the sunrise.
Okay.
Okay. All right. So we're going to now talk to or learn a little bit from patient experiences. There's three more important things that I want to draw to people's attention. We talk about these in the book because I think they have tremendous implications for what we're doing in treating patients. So the first thing we're going to do is talk a little bit about Takotsubo syndrome. This is a cardiac condition that was first identified in 1990 by Hikaru Sato in Japan. And it's also been termed broken heart syndrome, stress cardiomyopathy. And in 2018, it was through a consensus panel described as Takotsubo syndrome. It's a very interesting cardiac condition in that 90% of patients diagnosed with Takotsubo are women, so it tends to be much more affecting women than men. And 80% of those diagnosed are over 50. And so the question that I'm posing is it a cardiovascular condition, or could it be a trauma disorder that is mainly affecting heart function? So to kind of hear more about this, we have one of our patients who are here to talk about their life experience in terms of their Takotsubo event and how that impacted them, and then how they got better. So, Sandra, do you want to come up and tell us a little bit about your story? Thank you.
My pleasure. Hi, I'm Sandra Dudley, and I was lucky enough to go through a treatment program with Dr. Reitav. My problem started one Christmas when my very beloved granddaughter, who was suffering with schizophrenia, came to visit us and jumped off our 19th floor balcony to her death. And in the response to this, I experienced what the EMS people who were on site determined was a heart attack. So I was transported to the same hospital as my granddaughter, Sunnybrook, next door. And after, medical investigation, they determined that I had no organic heart disease. There was no blockage of arteries. There was only the conclusion of a Takotsubo that explained my heart attack. It was, in fact, a trauma response. So apparently, as a result of brain chemicals, which these two very learned people have, I think, very thoroughly explained. So that's what triggered it. The symptoms, though, in the early going, the symptoms were like any heart attack. I had damage to a muscle in the heart. I experienced, certainly in the immediate aftermath, extreme discomfort, chest pain, etc. I was in hospital for, I think, only about 10 days, and specifically asked to be referred to the rehab program here because my husband had been through the program after an organic heart attack some years earlier. And luckily for me, the rehab coordinator that I worked with had read my case file and knew that it was a Takotsubo and strongly recommended that I connect with Dr. Reitav. So really, I had probably normal symptoms of anyone suffering a heart attack in the early going days. But as time went by, I experienced initially some sleep issues, but they kind of went away over. I wasn't too fussed about it. I thought, I'm a good sleeper. I know I'll be a good sleeper again. I've been through this experience. It's not unexpected that you'd have some interruption of sleep. And sure enough, my sleep pattern returned to normal. And I started to recover. And every time I saw my cardiologist, he said, things are looking good. Gosh, the heart muscle is recovering. So the thing that motivated me to connect with Dr. Reitav and look for some help was the fact that psychologically, I was locked on this memory. I couldn't move past it. I mean, my granddaughter was 27 years old. I had many, many wonderful experiences with her before her illness led to these events. And I couldn't remember her or think of her in any context whatsoever, except that day. And the visuals that I was locked on as a result of that day, the coat that she left on the 19th floor balcony outside our windows, her purse, her body lying on the garden in the, in the area outside the condo. And so I was really seeking help with that, because certainly I was recovering physically. I was recovering in every other aspect. The various cardiac tests were showing that the heart muscle was recovering. And I would say all aspects of, certainly the exercise helped. We were fairly careful eaters, but the TRI offers you nutritional help. I mean, every kind of help you could possibly need. But the biggest help for me came through the work with Dr. Reitav. And it's not easy work. It's really quite difficult. You have to invest in the experience of reliving and reliving and reliving these events. And there's quite a lot of physical response to the therapy also. You experience chest pain, numbness, all kinds of different physical things occur as you go through the process of therapy and healing. And with every session, those things kind of, once you get over the first big curve, I think, those symptoms start to lessen. And you start to realize that that thing I was missing, that fabric of my life with my granddaughter, started to come back to me. And I felt a lot better. And I think, although I was putting a brave face on it, I was holding it together better as the therapy progressed. And it really made a huge, huge difference in my life. And we worked together, I think, over a period of 6 or 7 months at that time. And I sort of realized that my response to the therapy, all these physical, experiences were lessening and lessening, and I was doing better and better. And so we reached a stage where I said, I think that's it. I think I'm there. Everything is better. I now think of my granddaughter in this 360 spectrum, not in this little pinpoint that happened on that one day. And I would say, of all of the treatment, therapy, etc., this made the biggest difference in my life. I couldn't recommend it highly enough for anybody who's struggling with the aftermath of one of these events. And I'm the over 50-year-old female that is typically representative of these patients. And for me, it was life-changing, tremendously life-changing, and I'll be eternally grateful. So thank you for letting me share my story today.
Thank you so much, Sandra. So just to kind of pull a few threads together, and I think we can tell from Sandra's story that what's really critical, these are the diagnostic criteria, and there's ways that you can get points for. So being female, you get 25 points. Having an emotional trigger, such as what she went through, is 24 points. And there's a few other things. Most of what we see here is the effect of trauma on the heart. And so if you kind of use this rubric to evaluate patients, you can see that you can differentiate a Takotsubo heart attack from an acute coronary syndrome. So they are different. And I guess one of the most important things, I think, and Sandra alluded to, how that feeling of being kind of haunted by those events of the last day that her granddaughter was alive. All of that is driven by the sympathetic system and the adrenal system. And so it's like we are stuck in our emotional brain. And I guess the point that I want to make, and I think Sandra made it beautifully, is that when somebody's gone through that kind of a Takotsubo heart attack, there are two important things that need to be addressed. One of which is, how is the heart doing? And it does need to, pursue the normal cardiac rehab program to strengthen and to improve the function. But it also means that we need to be aware of any trauma or any traumatic responses, and to also treat those. And they're not always elements that are made available to patients going through these life events. So that was the first condition I wanted to bring up. The second is insomnia. So as you will all be aware, the name of our book was Putting Trauma to Sleep. So sleep seems to have an important role in what we're doing. And insomnia, I think, is a very interesting condition in that if you look at what is it that actually gets us to sleep, what is it that we can count on at the end of the day to put us to sleep. And what is very instrumental in that is, in this slide, you'll see this little green dot there, which is the ventrolateral preoptic area. And just below it in purple is the suprachiasmatic nucleus. The suprachiasmatic nucleus is the part of the brain that tracks if we're in daytime or nighttime. And of course, if you're alive, you're going to experience sunshine in the daytime and darkness at night. And so that area of the brain is constantly getting input from the environment we're in and tracking whether or not we're in daytime or nighttime. And so as you get into nighttime, it tells that ventrolateral preoptic area it's time for sleep. And what the ventrolateral preoptic area does is it quiets down, a very kind of unruly group of brainstem nuclei, all of which are responsible for making sure you stay alive. So at the end of the day, if there's no lion or tiger in your bedroom, they cooperate and they say, okay, you're right, let's go to sleep. And so that's what happens normally. Now, to kind of tie insomnia in with cardiac rehab and why it is important. So these are cardiovascular event-free survival this is across 12 or 13 years of study. This is a prospective study done in the US of adults, and they looked at people who had sleep problems. And some of these sleep problems were just short sleep. There are people that just need 5 hours of sleep a night. Others who had fragmented sleep, like they would wake up off and on, some of whom slept more than 6 hours, some of which slept less than 6 hours. So if you were in the group that had short sleep, less than 6 hours, and your sleep was fragmented, broken up into multiple awakenings, that's the group that had the most cardiac events, and significantly more cardiac events. So there is something about having that kind of phenotype of the sleep that is very restless, very fitting or fitful, and short. Now, this is a monograph that was published by a Dutch researcher. His name is Joos van Someren. And he made a very interesting conclusion. And his conclusion was that if you have this kind of broken sleep, it tends to be because your locus coeruleus is active when it should not be. So at night when we go to sleep, and again, that was this diagram here, the ventrolateral preoptic area should be quieting down that locus coeruleus. It should be calm and relaxed. But in people who have insomnia, short sleep and fragmented sleep, that area, the locus coeruleus, is not quieting down. And as a result, you have something which he called restless REM sleep. The other interesting thing that he highlighted is that when you do have insomnia with this restless REM, is that it doesn't permit your amygdala to adapt to any emotional challenges that you may be facing. So in this diagram, it's a little hard to see, but the upper picture from left to right is someone who has a fairly normal REM period, and in the morning their emotional system has been kind of reactivated and adapted to whatever the problem was. Whereas with insomnia, you don't get that adaptation. And the other important thing that you spent summer and concluded was that insomnia is not a sleep disorder at all. It's actually a disorder of the locus coeruleus being hyper aroused through the night. And in this diagram, you can see that the locus coeruleus is off to the right in purple, and its activation is now overwhelming and suppressing your sleep center. So you can't get that sleep center to actively get you to sleep, and it's activating your mind. So your mind is going a million miles an hour or whatever. And also it tends to activate the body by sending that kind of charge and activation down into the musculature. And if you track what the brain is doing in a healthy sleeper, you'll see these white bars in the first 3 hours of sleep. You see these very tall bars. These are called A1 subtypes, but what it is the brain is pushing you into deeper sleep. It's saying, you know, we've done our best in the daytime, we need to recover, and it's getting you into that slow wave sleep that's so necessary for our well-being. And then the dark bars, these are when the locus coeruleus is activating either motor responses or autonomic responses. And so this is a healthy sleeper, and now this is a person with insomnia. And you can see there's less of that drive into the slow wave sleep, and there's a lot more locus coeruleus activation keeping you awake. And the way that operates in the brain is that all of those brainstem nuclei around the two nuclei that are trying to promote REM sleep are interfering with it and basically derailing it. So with this as kind of the backdrop, I'm going to invite another of our guest speakers to come up. So Mike, do you want to come up and talk to us and the audience about your experience?
Thanks very much, Jaan, and thank you for asking me to share my experience with everybody. A little bit of a background. This is an experience that started in late 2020. At the time, I was 52 years old. I had no pre-existing conditions. I like to think I was in excellent health. And in late November of 2020, I was involved in a fairly serious motor vehicle collision. I was left unconscious for 10 to 15 minutes. I was taken to a hospital. They had done a number of tests. And in the end, they released me the following morning and said, I likely have a concussion. I thought, okay, great. Probably no big deal. You know, a concussion, a few weeks, I should be as good as normal and life can go on. But what was interesting is the first 4 weeks or so after my accident, I had generally fairly mild headaches. I was extremely tired, which was not typical for me at all. I was sleeping literally more than 10 hours a day, and on top of that, I was having naps in the afternoon. My energy level was very low, and anytime I looked at a screen, so computer, cell phone, TV, I would very quickly develop nausea and dizziness to the point where I would just have to immediately look away. Around the 4-week mark after my accident, things took a very significant change, and not necessarily for the positive. So my nausea and dizziness almost disappeared. My mild headaches turned into severe headaches to the point that I didn't even know you could have headaches that strong. So if it was just a migraine, I would have been okay, but this was over the top. And insomnia. So my sleep went from literally 10 plus hours a day down to an average for the first couple of months after that of below 3 hours a night, which was literally to the point where you're not even really functioning properly anymore cognitively. I had a number of other post-concussion symptoms as well, but they weren't anywhere nearly as detrimental as the insomnia and the headaches. So short-term memory issues, low energy, PTSD, hypersensitivity to noise and smell, and a few others as well. So I didn't really like myself in that state. I wasn't comfortable being incredibly uncomfortable, and just my energy level was atrocious. So I was fully determined to make a full recovery. I mean, there was no option. I was going to absolutely recover. I didn't really know how significant these post-concussion symptoms could be. So initially I tried a few different therapies that were recommended to me, physiotherapy, which literally did nothing. I spent some time with a chiropractor who apparently specialized in concussed patients, and that unfortunately didn't do anything either. And then somehow the stars aligned, and I was lucky enough to meet Dr. Reitav, and he introduced me to something called EMDR therapy, which is really all about managing my emotions. I'll talk a little bit more about how that improved my insomnia in a minute. There were also a number of other things that I did, like major changes to my diet, supplements, regular exercise, and then later on I also participated in other therapies such as mindfulness therapy, so just meditation, CBT, goal management, and some other things as well. So when I look back at my progress over the last almost 4.5 years, I actually did a sleep log, and in that sleep log I logged a whole bunch of other things too, including my diet, my exercise, what I did, what my daily feelings were like. So it wasn't that big of a deal. It was like 10 or 15 minutes a day, but it allowed me to go back and analyze, okay, what works and what didn't work. And one of the really amazing things is the EMDR therapy. Within about 3 months of taking EMDR therapy with Dr. Reitav, my insomnia improved tremendously. I went from averaging less than 3 hours a night of sleep over a monthly period to over 6 hours a night by August of 2021. So I was feeling pretty good. I thought, okay, great. You know, I'm probably fine. You know, I'm going to just keep recovering at this rate, and within a few months, I'll be right back to 100% of my old self. Things started to stabilize at that point. They didn't continue to improve, and then they actually dropped a little bit. But I was still okay. I was still averaging, 5.5, 6 hours a night. It was reasonably good sleep. And then on the anniversary of my sleep issues, my accident, I can't really explain why, but all of a sudden my sleep crashed and my headaches came back in full swing. And I was right back down to, literally averaging around 3 hours a night over prolonged periods of time. I had tried a number of other things during that time with, I'm going to say limited success, but maybe things that have helped. And then about a year after that, so on my second anniversary, things again crashed further. And then I called Dr. Reitav and said, I need help. And he introduced me to something new. He introduced me to something called DBR therapy. And it was all about mapping or I guess looking at the physical maps of my memories of my accident, recalling those physical maps and using those to sort of mitigate whatever my sleep issues were. And it was probably one of the most powerful therapies I've ever had. I mean, I was unconscious during and after the accident. So the fact that I could recall physical memories in almost like in slow motion of things that had happened to me during that collision was just profoundly incredible. And it had a new level of success overall. And I'll go through. So this is my sleep log data. So the very fine lines, the light yellow lines, those are my daily numbers, and the orange line is kind of a weekly rolling average. I'm a bit of a data geek, so you got to kind of excuse my data. You can see in the first EMDR, the first green arrow where we had the EMDR therapy, my sleep improved fairly dramatically, drastically, literally up to over 6 hours a night. And then it came down again. And then I tried a number of things and it was stable, but there was a lot of variability day to day. And this is fragmented sleep to the nth degree. So then in early 2023, it had dropped again. And then we started the DBR therapy. And there were really two benefits. So one, it had improved again and then remained at a reasonably stable level. But the consistency of my sleep improved drastically. So I no longer went from going from zero sleep to 6 hours to 3 hours to the next night of 4.5, back down to 0 to 7 to 3. It was all maybe 4.5, 6, 5, 5.5, 4. There was far less variability, and that makes a huge difference in terms of your energy level, in terms of your memory, and all kinds of other minor post-concussive symptoms that I had. So my sleep now is not perfect. It is far better than what it was initially, and certainly far better than what it was pre-DBR therapy. And the biggest benefit that I saw was the consistency of my sleep day to day. Overall, I would attribute literally 80% of my or more of the benefit that I've seen to my sleep, literally resulting from a combination of the EMDR and DBR therapies. My recommendation for anybody that has insomnia is take it seriously. It can be absolutely debilitating, and get help as urgently as you can. Address the root cause, which in my case was trauma. Although I had tried many different therapies, and I'd only listed a few, but it's probably more than a dozen different therapies. The EMDR and DBR therapies were by far the most effective in terms of treating my insomnia. There's a lot of work in this process. I mean, there's work during the sessions, not only for Dr. Reitav, but also for the patients. And I think you have to want to get better. You have to want to get back to a normal life. There's a lot of effort and pain and due diligence that you need to go through. You need to maintain a strong self-discipline. You really need to push yourself to get better. I also made significant changes in my diet, which I think have also helped to some extent. A good sleep hygiene, that sort of goes unsaid. And then other things like mindfulness training, meditation, breathing exercises that Dr. Reitav has also helped me with, also really help when you have those nights when you wake up at 1 or 2 in the morning and you want to fall asleep again. A daily log is something that I've recommended to a few people, and the initial response is always, "Oh my God, that seems like so much work." But the value in being able to track and analyze what works and what doesn't work, and often you can't tell by when you have a bad night of sleep. Okay, did something go wrong that one night? You really need to look at a bigger data set. So even with meals, if I eat something 10 times and I find out 8 times of those 10 I don't sleep well, okay, well then I'll stop eating that one certain something. And the same goes for many other things. Your screen time, type of exercise you do. I've learned that I shouldn't be exercising at nighttime, for example. So there's so much learning that on an individual level can come out of that. I would highly recommend it. And I think no matter how good the therapy, I think you have to expect a bit of a roller coaster ride. There is no quick cure that I'm aware of. And I think also, even with the best of therapy, I mean, some days it works, and other days it's not going to work as well as you would like it to. So all in all, I feel myself very fortunate. It's now been a few years, but my physical, my mental, my emotional state is exponentially greater than it was a few years ago, and I'm extremely grateful for that. So thank you very much.
Thank you, Mike. And you know, in my career in treating people, it's always the ones or the situations that come up that you scratch your head and say, this shouldn't happen. Why did this happen? That you learn the most. And so from Mike's situation where he had the difficulty with the relapse at the first anniversary, I wondered, what is going on? And I kind of went back to the drawing board and looked at how do we understand brain function. And this diagram helped me enormously in that what do we do when we're doing EMDR therapy? Well, the eyes are moving back and forth. So we're helping in the connection between the right and the left brain. And the right hemisphere is the part of the brain that's holding all of your emotions, all of your physical sensations, you know, the experience of having a heart attack. If you had a heart attack, in Mike's case, the experience of actually reliving that car accident, it's stored in that right brain. And so as you do the eye movements, you begin to be able to put words to what is happening, what you're sensing in your body, what you're feeling. And you can integrate the left and right hemispheres really, really well, which of course is also including your limbic system. But the part that isn't being affected in doing the EMDR is going back down to the brainstem level. And is it that we're getting any change or not? And I think that's where I went back to the drawing board and said, well, maybe there's something, another treatment that we can find that actively and specifically targets brainstem functioning. And that is what DBR is, deep brain reorienting work. And I'll explain that in a few minutes. Before I go there, though, I wanted to cover one additional issue, which is depression. So depression is very common among our cardiac patients. It's estimated that about 20% or 1 in 5 of our patients develop depression. And many of these never had depression in their lives. And then they have a heart attack and now they're struggling with their mood. Why? What's going on? So in the book, there is a case that I present, 53-year-old female, and she had just a crushing physical pain during her heart attack. And that triggered something that we would call a neurochemical dissociation. Neurochemical dissociation means that if you're in significant pain, you know, to the point that it's excruciating and literally you cannot tolerate it, your brain comes to your rescue and it releases something called dynorphin. And dynorphin is something that will make you feel like, oh, I don't feel any pain at all. So that's the good part of dynorphin. The bad part of dynorphin is that it makes your brain into kind of a brain fog state where you can't really focus your thoughts or think clearly or necessarily remember anything. So she came into our groups. We tried to do some EMDR. It didn't really make any big difference. So I thought, well, let's try DBR because I'd had some success with people like Mike. And so as we began treating, we sent her for a sleep test, which I do pretty regularly because many of our patients have apnea, and she did. And so she started using her CPAP. But in the sessions that we did the DBR work in, she would experience this huge crushing pain, which she called a big, heavy pain ball. I mean, it was, and again, it's hard for me to communicate how hard some of these sessions are because it's not like you remember about being somewhere back there, something happening to you. You feel it. You are once again in that state where you feel that activation in the right brain. So in total, we did 17 of these PBR treatment sessions. And in fact, it helped enormously in terms of removing the intensity of these experiences. And that allowed her to begin to talk about what happened without reliving the experience. And I think that's an important element of, you know, the difference between trauma and normal memory. So normal memory, you can think about something that happened, has a date stamp. You remember it was last week. But when you've had a trauma, you begin talking about it, you're re-experiencing it. It's really overwhelming. So the release of dynorphin for many of our patients, I think, is a hugely important issue, because when you have, and in the brainstem, all of these areas that I was talking about, the paraventricular nucleus, the locus coeruleus, the periaqueductal gray, and the dorsal raphe, all of them express dynorphin. And dynorphin, when those areas work together, recruit the lateral habenula, which is the center of the hub for aversion and avoidance behaviors that I don't want to go near. So if you've touched a hot stove and you kind of go and you start reaching for it, you'll have a hard time really putting your hand on that stove, because your brain remembers, don't touch that thing. So the lateral habenula is the center of aversion. And what it does is it then activates the what's called the rostromedial tegmental nucleus, which then shuts down your dopaminergic system. And your dopaminergic system is basically that part of the brain that leads you to be interested in the world, leads you to be curious about doing things and being active. And so when you've had this kind of a crushing pain experience, and the brain has released these dynorphin from these various brain centers, one of the casualties is that your whole system of activation from the ventral tegmental area shuts down. And that area is responsible for and activated during slow wave sleep. So what happens is that once that VTA is deactivated, your sleep is disturbed, and people will start waking up repeatedly through the night. And then once your sleep is suppressed for a long enough period of time, you become depressed. So the experience of depression follows after the sleep disturbance. And so this diagram just illustrates what's happening with the recruitment of the lateral habenula. So what I want to highlight is, so these clinical cases that are described in the book are all bringing our attention to something that's very important, which is that we can now understand that the area that we need to target in our psychological treatments is in the brainstem, right? And so if we go back to what the Cochrane review told us, that our understanding of psychological treatment effects are unlikely to be any clearer unless we clarify what is the mechanism to both the cardiac conditions as well as the psychological conditions. So I would propose that our answer to that is it's the locus coeruleus and all of its supporting nuclei that can kind of push you towards agitation, lack of sleep, insomnia, or in the event of crushing pain, towards depression. So those are very important issues in terms of treatment management. So again, if we kind of follow this line of reasoning, then most of the psychological treatments that we want to use with patients with these medical kinds of difficulties are not so much the upper level. So when we look at psychological treatments, we can describe them as kind of top-down treatments, which are very important treatments where, you know, you look at CBT, cognitive behavioral therapy, you look at your pattern of thinking in certain situations. So it's applying learning theory to making changes in the brain and what you're experiencing. But those top-down approaches don't target sufficiently what the brainstem is doing. And what I've learned from working with patients like Mike is that you need something that targets the brain at the brainstem level. And that is the survival brain, not the thinking brain, not the emotional brain, but the survival brain. And here, what's important, and that I've come to learn from working with a psychiatrist in Glasgow named Frank Corrigan, is that all three levels of brain contribute to your conscious experience. So we like to think that we're thinking beings, and so we can kind of be aware of what we're thinking about or what we're going to do after this presentation. We might also be able to drop down and begin to experience something that we're emotionally aware of. So we may be feeling excited. So I'm excited this finally this night when we can launch our book. So there's something going on emotionally. But if you kind of drop down even further, you can begin to connect with your body and your body's experience and where you feel tension, where you feel a tightness, where you feel some tension or waves of reactions coming and going. And it was Frank Corrigan's contribution that we can actually work with patients in guiding them to track what they're feeling and track their kind of lower down physical sensations. So the treatment, kind of in a nutshell, I'm not going to go into great detail, but really important in this work is that you first have the person ground in what he would call the aware self. So what that means is you bring their attention to the fact that right now they're seated, they can feel gravity pulling them into the chairs they're in, and from where you're located, you know how far in front of you the wall in front of you is, the wall beside you, the wall behind you. You can actually locate yourself in the room, and your brain is making a map that even though you can't see the wall behind you, there's no doubt in your brain that there's a wall there and that these walls create for you a safe and protected space. And so you start by bringing the person's attention to that sense of being grounded in a safe place. Then you bring back the memory. It's an activating stimulus that, in Mike's case, to use that as an example. Now remember when you were in the car and you could see that car coming directly in front of you. Okay. Now, as you see that car directly in front of you, what do you feel in your body, right? And as he goes back to the memory, he can feel his right foot going for the brake. Okay. So literally, you experience everything your brain did for you in that moment in the accident, but you're experiencing it in a safe environment, right? Because you've grounded the person in safety. And now the brain has a dilemma because it knows it's safe, but at the other hand, it's having these reactions of stabbing for the brake. So the brain's smart enough to say, I don't think I need this stabbing brake business anymore. I think I can rest in the present moment and calm down. And so the treatment itself is to bring back these memories and kind of allow the body to release these shock responses. So the brain, when it feels that you're in a life or death situation, it's activating the body, it's getting it going. And those shock responses kind of remain there. And when we're doing talk therapy, we don't talk about them. They don't really come up. We don't really speak to them. And so there isn't that ability to release them and let them go. So that's kind of in a nutshell what the advantage of using a treatment like that, which targets the brainstem, targets that locus coeruleus, and allows it to release the memories that the body is holding, is really, really important. So in conclusion, I'd like to just add that in addition to the two patients we heard from, that I've across the last 2 years as I've been working with Dr. Corrigan and using DBR therapy, that I've used DBR therapy with a number of patients, some of them from Toronto Rehab, some from my private office. But there are many medical conditions that result in those moments of, oh my God, I'm going to die. Among them, respiratory conditions, that those moments where I literally, I can't breathe, I can't draw any air into my lungs are terrifying, and they're overwhelming. And the brain is making a hologram of how it feels and holding on to it. So they have to be revisited and they have to be released. So all of these conditions, I think, could benefit from DBR therapy. However, that still needs to be demonstrated. What I think our book fits in is that it's making the case that from the examples, the patients who have offered their stories and participated in the writing of the book, whom I very much appreciate and acknowledge, have provided at least a roadmap forward that we can use to maybe test out in randomized control trials how many of these conditions can benefit from these kinds of conditions. So in terms of conclusions, for those of you who are medical patients, if you've experienced any kind of heart attack, respiratory condition, you name it, that all of those events are medical and they're emotional, because that locus coeruleus is going to activate all of those areas that we talked about. For hospital administrators, I think there's some takeaway as well, which is that any kind of medical condition that puts you in a life and death situation is going to activate different kinds of psychological symptoms, and psychological treatment may be helpful in helping those patients recover. To others, my colleagues who are in cardiac rehab programs, trauma and sleep, I would say, are important to keep in mind in all the work that you do. And for medical colleagues working in hospital settings, when you have patients that are complex and you have what are called medically unexplained symptoms, think about trauma and how an experience, a life and death experience, can cause that nervous system to hold on to some of these really overwhelming experiences. So with that, we're close to the end. So Dr. Thirlwell and myself have put together a website, puttingtraumatosleep.com, which has information for both patients as well as healthcare providers, because I think there's a real need for healthcare providers to learn more about what they can be doing to treat their patients more effectively. We're putting together a seminar, hopefully for June, to talk about insomnia seen through the lens of trauma, and hopefully by September or so, beginning to train people on sleep-informed trauma treatment. So with that, we've reached to the end of our presentation, and oh my gosh, at 8:01. It's like we practice this, but I did want to finish up to, first of all, to thank all of the cardiac rehab patients I've had the pleasure of treating. I think Paul estimated there was 35,000. I don't think that's true. There may not be that many, but there's certainly lots. And I've learned from all of you. Thank you for your participation in our programs. Thank you all for coming tonight, and for those online. And I think a special thank you. Celeste and I were taught by Dr. Harvey Moldovsky. He is a pioneer in psychiatric research and in sleep research, and it was through his rounds that we met and that brought us together, and which we're doing our best to kind of follow in his footsteps. And as well, Paul and Renee and all my colleagues here, Tracy, Lisa, there's so many of you. I am indeed so thankful that I have this as a home to work in and to enjoy learning and getting better at what we're supposed to do, which is helping our patients recover. So thank you all.
Doctor, before you ring off, could I make one comment?
Sure.
Brian Westlake speaking. I'm in the Apple Watch study that UHN is conducting. And on the subject of insomnia, which I don't have mercifully, it's very good for tracking your sleep patterns. It feeds into your iPhone, but I recommend anybody with sleep-related disorders that they consider getting an Apple Watch if you don't already have one. And it provides a complete track of what's going on. Anyway, I leave that with you. It's very useful to me.
Yeah, thanks, Brian. Okay, we'll park it there. We won't sell any more things right now, but we appreciate it. On that note, Jaan, Celeste, thank you so much for being here. You've all been magnificent. 90 minutes of all of this. You've learned a great deal. The brain is a complex place. It's so important and how it connects to the body. You've taken some fascinating science. You've learned lots of new words. Remember one, a blue dot, right? Okay, you want a healthy blue dot in the middle of your head. The rest will flow from there if we get it right. I think I learned that, but I heard this session twice, and that's what I've taken away. It has been a wonderfully informative evening. I'm mindful of your time. You've sat here patiently. Some of you may need to get on the road and get going. We understand that, but others may want to stay and ask some questions, so we can hang around. Jaan, Celeste, I'm sure you'll take some questions. There are books available in the back for those of you who are on site. You have the opportunity of meeting the authors, getting a book. For those of you who are online, I suspect we'll need to create an opportunity, Jaan, and there's probably going to be a whole bunch of things that folks want to ask, but we just, like, unless we're going to be here till midnight, I don't think we're going to get through all of it. But why don't we take just a couple of questions? Are there any folks with burning questions in the room? Anybody want to bring anything up? One, thank you, ma'am.
Just one. How many of patients that you treat have multiple medical traumas or physical traumas that go through these processes of EMDR and ABR to help? Just looking at how long I'm expected to be with you.
Sure. And why don't you come on up, repeat the question?
Yes.
And then I'll just make one comment of the folks online.
Yeah. So the question is, how many of the patients that I treat have multiple medical traumas or multiple medical conditions kind of overlapping with one another? And I would say many of the patients, there's some that just have a single medical issue, but being here at Cardiac, although it's called the Cardiac Rehab Center, we also have stroke patients, we have diabetic patients, we have cancer patients. So all of those patients can be seen by myself and my colleague Claire Peddle, our social worker, for treatment. So we treat the whole range, the whole spectrum of medical conditions. And Claire, like me, has been trained in EMDR and DBR. So we are kind of creating a small but mighty team of that has the skills to deal with what the patients need. So
super.
Thank you.
Well, thanks for that. And the other question that I'll just pull from the chat is, how can we get a book? That's what people want to know. How can they get a book for folks?
Joe, how do they get a book?
Online and offline, yeah. Okay.
So there is a link that they can get a book from Joe for, I think, a 20% discount if they actually.
Okay. And the link is in the flyer that invited you to this meeting. Yeah. And we can circulate additional information to the audience in a follow-up email. Okay. Yeah. But we'll make sure that you have the necessary links to get. And last question to the gentleman in the front.
Well, my daughter ordered 2 of them back in the summer, and we were told that they're going to be sent to our address.
Okay.
So why don't you talk to Joe at the back and he can sort you through. Okay.
We'll sort
but thank you. Advance order of 2 copies. Do I hear 3 and 4 and 5? Thank you very much. Well, that brings us to the end of this evening. Folks in the room, let's congratulate Jaan and Celeste. And all of you, thank you for being here. Safe drives home. And there'll be undoubtedly more follow-up to come. Folks in the room, so thank you online. We'll let you go at this point.